Hey guys, welcome to another episode of the Human AI podcast. Today we're going to be talking about renal disease and asthma. I am temporarily toothless because I'm going to be having an implant next week. So if my voice is a bit funny, well, so be it. Having said that, let's start our conversation with renal disease. I'm here with Grog. Grog is going to be helping us out to understand the concepts. By all means, guys, I'm not a teacher, I'm just a student, and I'm just trying to learn with the help of AI. Take everything that AI says with a pinch of salt, and without further ado, let's do it. So, Grog, when I come to hospital, I'm a patient, I'm a doctor. I want to know if I have renal disease. So how do we diagnose renal disease?
All right, let's dive into diagnosing renal disease. When you're at the hospital, whether as a patient or a doctor, the process typically starts with a combination of clinical evaluation, lab tests, and imaging. First, you look at symptoms like swelling, high blood pressure, or changes in urination, less urine, blood in urine, or foamy urine. Then, blood tests are key. Checking serum creatinine and blood urea nitrogen levels helps calculate the glomerular filtration rate, or GFR, which shows how well the kidneys are filtering. A GFR below 60 often flags kidney issues. Urine tests are also critical. Protein or blood in the urine can point to damage. Imaging, like an ultrasound or CT scan, can spot structural problems or blockages. Sometimes, a kidney biopsy is needed for a definitive diagnosis, especially for conditions like glomerulonephritis.
What is DMSA and MAG3?
I'm assuming you're asking about the difference between a MAG3 renal scan and other kidney diagnostic
And then
tests.
DMSA.
All right, it sounds like you're asking about the differences between a MAG3 renal scan and a DMSA scan in the context of diagnosing renal disease. Let's clarify that. Both are nuclear medicine tests used to evaluate kidney function, but they serve different purposes. A MAG3 scan, using mercaptoacetyl triglycine, is dynamic and focuses on kidney blood flow, filtration, and drainage. It's great for detecting obstructions, like in the ureters, or assessing how well the kidneys are working, especially in cases of suspected blockages or reduced function. A DMSA scan, using dimercaptosuccinic acid, is static and zeroes in on the kidney tissue itself. It's used to detect scarring, infections, or structural abnormalities, like in pyelonephritis or congenital defects.
I see. And how do we differentiate between acute and chronic kidney disease? What are the different symptoms and presentations?
Differentiating between acute kidney injury, or AKI, and chronic kidney disease, CKI, comes down to the timeline, causes, and clinical presentation. AKI happens suddenly, often within hours or days, and is usually triggered by something like dehydration, severe infection, drug toxicity, or reduced blood flow to the kidneys, say from shock. Symptoms can include a sharp drop in urine output, swelling in the legs or face, fatigue, nausea, or confusion. It's often reversible if caught early. CKI, on the other hand, develops slowly over months or years, commonly from conditions like diabetes, hypertension, or glomerulonephritis. Symptoms might not show up until late stages, but they include persistent fatigue, itchy skin, frequent urination at night, high blood pressure, or foamy urine from protein loss. Blood tests are key. In AKI, creatinine spikes quickly. In CKI, it rises gradually, and GFR is consistently low. Urine output in CKI might be normal early on, unlike the often reduced output in AKI. Imaging or biopsy can help pinpoint underlying causes, especially for CKI. Want me to dig into any specific test or symptom further?
So, okay, let's continue. Okay, got that. Why is one called acute kidney injury and the other one is called chronic kidney disease? Why disease and injury? Why this difference?
Good question. It's about the nature and timing of the conditions. Acute kidney injury, AKI, is called an injury because it's a sudden, often temporary hit to kidney function, like a trauma or insult from something like severe dehydration, a toxic drug, or low blood flow. The term emphasizes the abrupt onset and potential for recovery if the cause is addressed quickly. Chronic kidney disease, CKI, is labeled a disease because it's a long-term, progressive condition where kidney damage or reduced function develops gradually, often from ongoing issues like diabetes or hypertension. The disease part reflects its chronic, systemic nature and the fact that it's usually not fully reversible, though it can be managed. The terminology highlights the difference in urgency and progression. AKI is an emergency, while CKI is a slow burn. Anything else you want to explore about these terms or their implications?
Interesting. Okay, so a GFR to be normal is around 120. Tell us about the different scores.
All right, let's talk about glomerular filtration rate, or GFR, and its scores. GFR measures how well your kidneys filter blood, and it's a key indicator of kidney health. A normal GFR is typically around 90 to 120 milliliters per minute per 1.73 square meters of body surface area, though it can vary slightly by age, sex, and lab standards. As you age, GFR naturally declines a bit. Here's the breakdown of GFR scores and what they mean. 90 to 120 milliliters per minute per 1.73 square meters of body surface area. Above 90, generally normal kidney function, assuming no other signs of kidney damage, like protein in the urine. 60 to 89, stage 1 or 2 chronic kidney disease, if there's evidence of kidney damage, like proteinuria or abnormal imaging. Often, people feel fine at this stage. 30 to 59, stage 3 CKI. Symptoms like fatigue, swelling, or high blood pressure might start showing up. This is where management gets critical. 15 to 29, stage 4 CKI. Severe kidney damage, with symptoms like itching, poor appetite, or nausea becoming more common. Planning for dialysis or transplant might begin. Below 15, stage 5 CKI or kidney failure. Dialysis or a transplant is usually needed to survive. These stages help guide treatment and monitoring. GFR is calculated using blood creatinine, age, sex, and sometimes race in equations like CKD, EPI. If you're seeing a GFR below 60, it's a red flag for kidney issues, even without symptoms. Want me to dive deeper into how GFR is calculated or what to do at specific stages?
I will ask a question, and it's, I know that these numbers have come from empirical evidence of the symptoms and signs. But for instance, why do you think that specifically this amount of rate, this specific rate, has these symptoms and signs? Guys, I don't like, I cannot say s very good now with my tooth. It's my front tooth, guys. I will get an implant on Thursday. Now I look a bit silly.
No worries about the tooth. You'll be rocking that implant in no time. Let's get to your question about why specific GFR ranges correlate with certain symptoms and signs in kidney disease. The GFR numbers, like 90, 60, 30, or 15, aren't just arbitrary. They reflect how much kidney function is left and how that impacts the body's ability to filter waste, balance fluids, and regulate electrolytes. Here's the deal. At a GFR above 90, the kidneys are working well, clearing toxins like creatinine and maintaining balance, so you usually don't feel anything off. As GFR drops to 60 to 89, some filtering capacity is lost, but the kidneys can still compensate, so symptoms are often absent unless there's underlying damage, like protein leaking into urine. When GFR hits 30 to 59, waste starts building up more, and the kidneys struggle to manage fluid and electrolytes, leading to swelling, high blood pressure, or fatigue. Below 30, at stages 4 and 5, the kidneys are barely filtering. Toxins like urea accumulate, causing nausea, itching, or neurological issues, and fluid overload can lead to heart strain or breathing trouble. These thresholds were set based on decades of clinical studies tracking patient outcomes, symptoms, and lab results, like those from the National Kidney Foundation. The symptoms tied directly to the kidney's declining ability to do their job. Want me to break down a specific stage or symptom further, or maybe touch on how treatments target these issues? And good luck with that implant.
Sure. I wanna ask you about
So,
like how do I suspect that I have a kidney problem? Because yeah, when do I because GFR has to be really low to actually start having problems visible, right?
great question. Suspecting a kidney problem can be tricky because you're right, GFR often has to drop quite a bit, like below 60 or even 30 before obvious symptoms kick in, especially with chronic kidney disease. But there are clues to watch for, even earlier, that can raise suspicion. If you're at home or in a clinic, here's what to look out for. Changes in urination are a big red flag. Things like peeing less, seeing blood in your urine, or noticing foamy urine, which can signal protein leakage. Swelling in your legs, ankles, or around your eyes from fluid buildup is another hint. Feeling unusually tired, weak, or short of breath can point to anemia or toxin buildup, which kidneys normally handle. High blood pressure, especially if it's new or hard to control, is a common sign, as kidneys regulate blood pressure. Itchy skin, a metallic taste in your mouth, or nausea can also suggest waste products piling up. Now, early on, with a GFR still above 60, you might not feel anything, which is why routine checkups are key. A simple blood test showing elevated creatinine or a urine test with protein or blood can catch issues before symptoms hit. Risk factors like diabetes, hypertension, family history of kidney disease, or frequent use of meds like NSAIDs also raise suspicion and warrant screening. If you're noticing any of these signs or have risk factors, it's worth getting a blood or urine test to check GFR and kidney function. Want me to go into how doctors confirm the suspicion with specific tests, or what you can do to protect your kidneys if you're worried?
Yes.
All right, let's dig into how doctors confirm a suspected kidney problem and what you can do to protect your kidneys if you're worried. If you've got symptoms like swelling, changes in urination, fatigue, or high blood pressure, or even if you're symptom-free but have risk factors like diabetes or a family history, doctors start with some straightforward tests. A blood test for serum creatinine is usually first. It's used to estimate your GFR, which shows how well your kidneys are filtering. A GFR below 60 is a red flag, even if you feel fine. Next, a urinalysis checks for protein, blood, or other abnormalities in the urine. Proteinuria, or too much protein in the urine, often shows up before symptoms get bad. Doctors might also order a urine albumin to creatinine ratio test to catch early damage, especially in high-risk folks. Imaging, like an ultrasound or CT scan, can spot structural issues, blockages, or cysts, while a kidney biopsy might be needed for specific conditions like glomerulonephritis. To protect your kidneys proactively, especially if you're worried, keep blood pressure and blood sugar in check. Diabetes and hypertension are the top causes of kidney damage. Stay hydrated, but don't overdo it, and avoid frequent use of kidney-stressing meds like ibuprofen. A balanced diet low in salt and processed foods helps, and if you smoke, quitting is a big win for kidney health. Regular checkups with blood and urine tests are crucial if you're at risk, as catching problems early can slow or stop progression. Anything specific about these tests or prevention steps you want to dive deeper into?
Um, I wanna ask you about our other topic of the day. Sorry, I'm a bit slow today, guys. Asthma. So asthma is a weird one, right? Because we don't exactly know what causes it. Or I may be mistaken. Correct me if I'm wrong. Give us a definition of asthma, and let's work our way from there.
No worries at all. Let's switch gears to asthma. You're not entirely mistaken. Asthma's causes aren't fully pinned down, but we know a lot about what triggers it. Asthma is a chronic lung condition where the airways become inflamed, narrow, and produce extra mucus, making it hard to breathe. It often shows up as wheezing, shortness of breath, chest tightness, or coughing, especially at night or early morning. These symptoms can flare up in episodes called asthma attacks, triggered by things like allergens, pollen, dust mites, cold air, exercise, smoke, or stress. While we don't know the exact cause, it's likely a mix of genetics and environment. If you have a family history of asthma or allergies, you're more at risk, and exposure to pollutants or early infections can play a role. Unlike some conditions, asthma isn't one size fits all. It varies in severity and triggers from person to person. Want me to break down how it's diagnosed or what sets off those attacks in more detail?
Well, yes. Also, I want to ask a bit about the pathophysiology of asthma. If you could summarize everything in 2-3 sentences, though.
Asthma is a chronic lung condition where airways inflame, narrow, and produce excess mucus, causing wheezing, shortness of breath, and coughing, often triggered by allergens, exercise, or irritants. Its pathophysiology involves airway inflammation driven by immune responses, particularly involving eosinophils and T helper cells, leading to bronchoconstriction and mucus hypersecretion. Diagnosis relies on symptom history, lung function tests like spirometry showing reversible airflow obstruction, and sometimes bronchial challenge tests to confirm airway hyperresponsiveness.
And what are some of the asthma phenotypes?
Asthma phenotypes are the different ways asthma presents, based on triggers, symptoms, and underlying mechanisms. One common phenotype is allergic asthma, often linked to allergens like pollen or pet dander, with early onset, and a strong tie to conditions like eczema or hay fever. Non-allergic asthma, triggered by factors like stress, exercise, or cold air, tends to start later and may be tougher to manage. Eosinophilic asthma involves high levels of eosinophils, a type of white blood cell, driving severe inflammation, often seen in adults and requiring targeted therapies like biologics. Neutrophilic asthma, less common, is linked to infections or pollutants and involves neutrophils, often resisting typical treatments. Then there's exercise-induced asthma, where physical activity triggers airway narrowing, and obesity-associated asthma, where excess weight worsens symptoms. Each phenotype guides treatment, as they respond differently to meds like inhalers or biologics. Want me to zoom in on one of these or how they're identified?
What about cough variant asthma and cough predominant asthma?
Cough variant asthma and cough predominant asthma are specific asthma phenotypes where coughing is the main or most prominent symptom rather than wheezing or shortness of breath. Cough variant asthma is a type where chronic cough is the only symptom, no wheezing or breathlessness during episodes. It's often triggered by typical asthma triggers like allergens, cold air, or exercise, and is more common in kids or those with mild asthma. Cough predominant asthma, on the other hand, involves coughing as the primary symptom, but patients may also have mild wheezing or shortness of breath during flares. Both can be tricky to diagnose because cough can stem from other causes, like GERD or postnasal drip. Diagnosis.
Yes, I interrupted. I was just going to ask, what is the diagnosis process?
No problem at all. Let's wrap up cough variant and cough predominant asthma and dive into their diagnosis
In
process.
general, what's the diagnosis for all these types of asthma? If you could sell it in 2-3 sentences, let's keep it nice and flowy.
Diagnosing asthma, including all its types, like cough variant or allergic, starts with a detailed history of symptoms such as wheezing, coughing, or shortness of breath, especially if triggered by allergens, exercise, or irritants. Doctors use lung function tests like spirometry to confirm reversible airway obstruction and may perform bronchial challenge tests or exhaled nitric oxide measurements to assess airway inflammation. If cough is the main symptom, as in cough variant asthma, ruling out other causes like GERD or infections is key before confirming with asthma-specific tests.
Okay. So I don't understand, to be honest. The diagnosis, if you could explain again.
No worries, let's break down asthma diagnosis in a simpler way. To figure out if someone has asthma, including any type like allergic or cough variant, doctors first ask about symptoms: wheezing, shortness of breath, chest tightness, or chronic cough, and whether things like pollen, exercise, or smoke make them worse. They also check your medical history, like allergies or family asthma. Then, they do a key test called spirometry, where you blow into a machine to measure how much and how fast you can breathe out, to see if your airways are partly blocked but improve after using an inhaler.
And what is a peak expiratory flow rate variation?
Peak expiratory flow rate, or PEFR, variation is a measure used to help diagnose and monitor asthma by tracking how much the maximum speed of air you can blow out changes over time. You use a hand.
Yes, you use a hand.
I think you meant inhaler there, not hand. But I got you. Let's pick up where we left off with asthma diagnosis, keeping it clear and simple.
No, peak expiratory flow rate variation. So explain us this.
My bad. Thanks for clarifying. Let's talk about peak
Yeah,
expiratory flow.
Brother, don't repeat what I say. Just answer. And not only now, every single time, okay? Please.
Got it. I'll keep it straight to the answer. Peak expiratory flow rate, or PEFR, is a simple test to measure how fast you can blow air out of your lungs, using a handheld device called a peak flow meter. It helps diagnose asthma by showing if your airways are narrowed. Variations in PEFR readings, like lower values in the morning or after triggers like exercise, suggest asthma. You blow into the meter a few times daily, and if the numbers drop significantly, say by 20% or more, or improve after using an inhaler, it supports an asthma diagnosis. It's especially useful for monitoring.
Okay, so basically, it's because when it's low, it means it's asthma.
Not exactly. Low PEFR alone doesn't confirm asthma, but it can be a clue. A low peak expiratory flow rate means your airways might be narrowed, which happens in asthma when they're inflamed or constricted. However, other conditions like COPD or a lung infection can also lower PEFR. For asthma, doctors look for variation in PEFR readings, like if it's lower in the morning, after exercise,
So
or during
it's more of
symptoms.
an intermittent thing, asthma. It goes and comes.
Yeah, exactly. Asthma is often intermittent.
And
Symptom-
what about the bronchial challenge test?
The bronchial challenge test is a diagnostic tool used to confirm asthma by testing how sensitive your airways are. You inhale a substance, like methacholine or mannitol, that can cause airways to narrow in people with asthma. Then, you do a breathing test, usually spirometry, to measure how much your lung function drops. If your airways overreact and your breathing capacity decreases significantly, it strongly suggests asthma. It's especially helpful when symptoms are unclear or spirometry and peak flow tests aren't conclusive, like in cough variant asthma. The test is done under medical supervision since it can trigger asthma symptoms. Want me to explain how it fits into the bigger picture of asthma diagnosis or something else?
Yeah, explain this a bit more. I don't understand this bronchial challenge test.
All right, let's break down the bronchial challenge test super clearly. It's a test to see if your airways are overly sensitive, which is a hallmark of asthma. Here's how it works. You breathe in a small, controlled amount of a substance, like methacholine, which is known to mildly irritate airways in people with asthma, causing them to tighten. Before and after inhaling it, you do a spirometry test, where you blow into a machine to measure how much air you can exhale and how fast. If your lung function drops by a certain amount, like 20% or more, after the methacholine, It shows your airways are hyperresponsive, pointing to asthma. The test is carefully monitored by a doctor because it can cause wheezing or breathlessness, and they'll give you an inhaler to reverse any effects right away. It's used when other tests, like spirometry or peak flow, aren't clear, especially for tricky cases like cough variant asthma, where symptoms are less obvious. Think of it like a stress test for your lungs to reveal asthma that's hiding. Want me to go into how doctors decide when to use this test
Got
or
it.
compare?
Okay, that makes a lot of sense. And what about mannitol, eucapnic hyperventilation, indirect challenge test? So we have direct and indirect.
All right, let's dive into mannitol, eucapnic hyperventilation, and the difference between direct and indirect bronchial challenge tests. A mannitol challenge is an indirect test where you inhale dry mannitol powder in increasing doses. It draws water out of airway cells, mimicking what happens during exercise or dry air breathing, which can trigger airway narrowing in people with asthma. You do spirometry after each dose, and if your lung function drops significantly, like by 15% or more,
And why we call the mannitol eucapnic indirect?
Okay, let's clear up why mannitol and eucapnic voluntary hyperventilation are called indirect challenge tests. Indirect tests, like these, trigger asthma symptoms by mimicking natural conditions that cause airway narrowing, rather than directly irritating the airways. Mannitol works by dehydrating airway cells, which releases inflammatory mediators like histamine, indirectly causing airway constriction in people with asthma. Eucapnic voluntary hyperventilation involves rapid, deep breathing of dry air while maintaining normal carbon dioxide levels. That's the eucapnic part, which stresses the airways and triggers narrowing, similar to exercise. These differ from direct tests, like methacholine, which directly stimulate airway muscles to contract. Indirect tests are more specific to asthma because they reflect real-world triggers like exercise or dry air, and are less likely to give false positives in non-asthma conditions. Want me to go deeper into how these tests are chosen or their results?
I don't understand. I don't understand why one is indirect and the other is direct. If you could answer in 2-3 sentences.
Direct challenge tests, like methacholine, directly stimulate airway muscles to tighten, quickly showing if airways are overly sensitive in asthma. Indirect tests, like mannitol or eucapnic voluntary hyperventilation, mimic natural triggers such as exercise or dry air, causing airway narrowing through inflammatory mediators, not direct muscle stimulation. This makes indirect tests more specific to asthma as they reflect real-world scenarios.
Okay. I see.
Glad that clicked. Want
So
to
why
dive
is
into
it okay? So why does the mannitol eucapnic test not show? Why is it not a real world scenario?
I think you meant to ask why the mannitol or eucapnic voluntary hyperventilation tests are considered real-world
No,
scenarios.
the opposite. I asked you the opposite. Why the indirect? Why is the mannitol one not a real world simulation scenario?
Got it. Sorry for the mix-up. The mannitol test is considered a real-world scenario because it mimics natural asthma triggers, like dry air or exercise, by dehydrating airway cells and prompting an inflammatory response that narrows airways in asthmatics. However, if you're asking why it might not perfectly reflect real-world conditions...
Wait, dude, you told me that the direct one mimics real world. That's why it's called direct, right?
My bad. Let's clear this up. I think there's been some confusion. Direct challenge tests, like methacholine, don't mimic real-world scenarios. They directly stimulate airway muscles to contract, acting fast to test airway sensitivity, which is why they're called direct. Indirect tests, like mannitol or eucapnic voluntary hyperventilation, are the ones that mimic real-world triggers, like exercise or dry air, by causing airway narrowing through natural inflammatory processes. So, mannitol is actually designed to reflect real-world conditions.
Why is more natural than the other?
Indirect tests, like mannitol or eucapnic voluntary hyperventilation, are more natural because they trigger airway narrowing by mimicking everyday asthma triggers, such as exercise, dry air, or asthmatic changes, which cause inflammation and mediate a release similar to real-life scenarios. Direct tests, like methacholine, aren't natural. They chemically force airway muscles to contract without involving the body's usual inflammatory pathways, which doesn't happen outside a lab. This makes indirect tests better at reflecting how asthma.
All right. Okay. And what about exhaled nitric oxide?
Exhaled nitric oxide, or FeNO, is a test that measures the level of nitric oxide gas in your breath, which is a marker of airway inflammation, especially in asthma. You blow into a handheld device, and high FeNO levels, typically above 50 parts per billion in adults, suggest eosinophilic inflammation, common in allergic asthma. It's non-invasive, quick, and helps confirm asthma, guide treatment, or monitor how well meds like inhaled steroids are working, particularly for phenotypes like eosinophilic asthma. Want me to explain how it fits into diagnosing
how
asthma?
does it work? I don't understand.
All right, let's break down how the exhaled nitric oxide FeNO test works. When your airways are inflamed, especially in asthma types like allergic or eosinophilic, immune cells, like eosinophils, produce more nitric oxide gas as part of the inflammatory process. You breathe out steadily into a small, handheld FeNO device, which measures the nitric oxide level in parts per billion. A high reading, say above 50 ppb in adults, indicates airway inflammation, supporting an asthma diagnosis or showing if treatments
why a high nitric oxide concentration means that I have inflammation?
High nitric oxide in your breath signals airway inflammation because, in asthma, especially allergic or eosinophilic types, activated immune cells like eosinophils produce more nitric oxide as they drive inflammation in the airways. This gas is a byproduct of the inflammatory process, so when you exhale and an FeNO device measures elevated levels, it reflects that ongoing immune activity in your lungs. It's like a smoke signal from the inflammation fire, helping doctors confirm asthma or check if it's under control. Want me to dive into how this helps with treatment decisions or something else?
I want to ask about the skin prick testing, serum IgE, and blood eosinophilia, and how it can help us understand asthma. If you could give us 3 sentences, one for each, but give me one more initial sentence about why high nitric oxide suggests inflammation.
High nitric oxide in exhaled breath indicates airway inflammation because it's produced by activated immune cells, like eosinophils, during the inflammatory response in asthma. Skin prick testing introduces small amounts of allergens to the skin to check for allergic reactions, helping identify triggers like pollen or dust mites that drive allergic asthma.
I don't get
Serum?
it. Can you repeat this?
Sure. Let's go over it again clearly. High nitric oxide in your breath shows airway inflammation because immune cells, like eosinophils, release it as they cause inflammation in asthma.
Okay.
Skin prick testing
Why do
involves...
they release it?
I'm guessing you meant why the variability or
No,
something
I
similar.
said why the immune cells release the nitric oxide.
My apologies for the mix-up. Immune cells, like eosinophils, release nitric oxide during asthma because they get activated by allergens or irritants, triggering an inflammatory response in the airways. Nitric oxide is produced as a signaling molecule in this process, helping coordinate the immune reaction, and its high levels in breath reflect that inflammation is active in the lungs. Want me to tie this back to the skin prick, serum IgE, or eosinophilia tests, or go somewhere else?
Brother, I don't understand.
No worries. Let's make this super simple. In asthma, when allergens like pollen hit your airways, immune cells like eosinophils kick into gear to fight them. And as they do, they pump out nitric oxide
But
as
why
part...
they pump nitric oxide?
All right, let's get to the core of it. Immune cells like eosinophils pump out nitric oxide in asthma because it's a natural byproduct of their activation. When allergens or irritants trigger an immune response, these cells release nitric oxide as a signaling molecule to help regulate inflammation and fight what they see as a threat.
What is this chemical byproduct? What is the equation?
Nitric oxide, NO, is a gas produced as a byproduct when immune cells, like eosinophils, are activated during asthma inflammation.
You're saying the same thing. I'm asking you, when they're activated, what is the chemical reaction that occurs? Don't repeat what I say, answer what I say.
When immune cells, like eosinophils, are activated in asthma, the enzyme inducible nitric oxide synthase, INOS, catalyzes a reaction where L-arginine and oxygen are converted into nitric oxide, NO, and L-citrulline. The simplified chemical equation is L-arginine plus O2 to NO plus L-citrulline.
Where did we find the L-arginine?
L-arginine is an amino acid naturally present in the body, found in the cytoplasm of immune cells like eosinophils. It's sourced from dietary proteins and synthesized internally, readily available for the inducible nitric oxide synthase, INOS, enzyme to convert into nitric oxide during inflammation. Want me to explain how this ties into asthma inflammation or something else?
I don't understand where we found the L-arginine.
L-arginine is already inside immune cells, like eosinophils, because it's a common amino acid the body gets from foods like meat, nuts, or beans, and also makes on its own through metabolic processes. It's stored in the cell's cytoplasm, ready for the enzyme INOS to use when inflammation.
And what makes L-arginine special so it fits into this kind of function? So how does its structure relates to its function? And the name too.
L-arginine is special because its chemical structure has a guanidine group, which allows it to serve as a substrate for the enzyme inducible nitric oxide synthase, INOS, to produce nitric oxide, NO, during inflammation. This structure, with its specific arrangement of nitrogen and carbon atoms, chemical formula C6H14.
Okay. Before we go to skin prick testing and all that, I want to ask, can you have acute asthma too?
Yes, you can have acute asthma, which refers to sudden, severe asthma attacks or exacerbations where airways rapidly inflame and narrow, causing intense wheezing, shortness of breath, or chest tightness. These episodes are often triggered by allergens, infections, or irritants, and require urgent treatment like inhalers or steroids to open airways. Unlike chronic asthma, which is ongoing, acute asthma is about these short, intense flares that can be life-threatening if not managed quickly. Want me to connect this to skin prick testing or stick with acute asthma for a bit?
Yes, let's go to skin prick testing and serum IgE and blood eosinophilia.
All right, let's dive into skin prick testing, serum IgE, and blood eosinophilia, and how they help understand asthma, keeping it concise. Skin prick testing involves placing small drops of allergens, like pollen or dust mites, on your skin and lightly pricking the surface. If a red, itchy bump forms within 15 minutes, it indicates an allergic sensitivity, pointing to allergic asthma triggers. Serum IgE testing measures levels of immunoglobulin E antibodies in your blood. High total IgE or specific IgE to allergens suggests an allergic response driving asthma, especially in allergic phenotypes.
And how do we measure the IgE?
Serum IgE is measured through a blood test, where a sample is analyzed in a lab using techniques like enzyme-linked immunosorbent assay, ELISA, or radioallergy sorbent test, RAST. These methods detect either total IgE levels or specific IgE antibodies to particular allergens, like pollen or dust mites, by binding them to a substrate and measuring the reaction, usually reported in international units per milliliter.
And what
IU
is this blood eosinophilia? How do we measure it?
Blood eosinophilia means having a higher than normal number of eosinophils, a type of white blood cell, in your blood, which is common in allergic or eosinophilic asthma. It's measured through a complete blood count, CBC, with a differential, where a blood sample is analyzed in a lab to count eosinophils, typically reported as a
How do we
percentage.
analyze it?
To analyze blood eosinophilia, a lab performs a complete blood count, CBC, with a differential test on a blood sample, usually drawn from a vein. The sample is processed using an automated hematology analyzer or manual microscopy, where eosinophils are identified and counted, expressed as either a percentage of total white blood cells or an absolute count per microliter, with levels above 500 per microliter often
I don't
indicating
get it. I don't understand.
No problem. Let's make it super clear. To check for blood eosinophilia, a doctor takes a small blood sample from your arm and sends it to a lab. There, a machine or a technician counts the eosinophils, a type of white blood cell, either as a percentage of all white cells or as a number per microliter, and if it's high, like over 500, it can point to asthma, especially the eosinophilic type. Want me to explain any part of this process or how it connects to asthma diagnosis?
Well, yeah, and also I want to tell me again skin prick testing what it is, and tell me again how we measure serum IgE and blood eosinophilia in a sentence each, and then let's talk also about biologics therapies.
All right, let's recap and then move to biologics. Skin prick testing places tiny amounts of allergens, like pollen, on your skin and pricks it. A red, itchy bump within 15 minutes shows you're allergic, helping identify asthma triggers. Serum IgE is measured by a blood test using techniques like ELISA to detect total or allergen-specific IgE antibodies, indicating allergic asthma if levels are high. Blood eosinophilia is checked via a complete blood count with differential, counting eosinophils in a blood sample, with high counts over 500 per microliter, suggesting eosinophilic asthma. Now, biologics are targeted therapies like monoclonal antibodies, e.g., omalizumab or mepolizumab, given by injection to block specific pathways such as IgE or eosinophil-related inflammation in severe asthma cases that don't respond to standard inhalers. They're game changers for allergic or eosinophilic asthma, reducing attacks and steroid use. Want me to dive deeper into how biologics work, or which ones target specific asthma types? Where you left?
Can we talk about the biologics therapies in regard to asthma, please?
All right, let's dive into biologic therapies for asthma. These are targeted treatments, usually monoclonal antibodies, designed to tackle specific pathways driving asthma, especially severe or eosinophilic types. Drugs like omalizumab, mepolizumab, and dupilumab work by blocking things like IgE or interleukins, reducing inflammation and flare-ups. They're game changers for folks who don't respond to standard inhalers, cutting hospital visits and improving quality of life. You want me to zoom in on how they work, their side effects, or maybe who qualifies for them?
Yeah, explain them a bit more. So they might be anti-IgE. What are they? Anti-TSLP, anti-IL4R, anti-IL5.
Okay, let's break down these biologic therapies for asthma a bit more, focusing on what you mentioned. These drugs target specific molecules or pathways that fuel asthma's inflammation, particularly in severe cases. Anti-IgE, like omalizumab, binds to immunoglobulin E, which triggers allergic reactions, reducing asthma attacks in allergic asthma. Anti-IL-5 drugs, such as mepolizumab or benralizumab, Target interleukin 5 to lower eosinophil levels, a type of white blood cell driving inflammation in eosinophilic asthma. Anti-IL-4R, like dupilumab, blocks the interleukin 4 receptor, calming down multiple inflammatory pathways for both allergic and non-allergic asthma. Anti-TSLP, a newer one like tezepelumab, targets thymic stromal lymphopoietin, a molecule early in the inflammation cascade, helping a broader range of asthma patients. Each zeroes in on a different driver of asthma to cut down flares and improve breathing. Want me to dig into one of these specifically, maybe their effectiveness or side effects?
I want to ask about, do we have an algorithm, an asthma treatment algorithm?
Yeah, there are asthma treatment algorithms, and they're pretty structured to guide doctors in managing asthma based on severity and control. The Global Initiative for Asthma, GINA, provides a widely used one. It starts with assessing symptoms, lung function, and triggers, then steps through treatment options. For mild asthma, it's usually low-dose inhaled corticosteroids, ICS, with a short-acting reliever like albuterol. Moderate cases might add a long-acting beta agonist, LABA, or increase ICS dose. Severe or uncontrolled asthma brings in biologics like the anti-IgE, IL-5, or TSLP we talked about, if patients meet specific criteria, like high eosinophils or allergic triggers. The algorithm emphasizes regular monitoring, stepping up or down based on control, and addressing triggers like allergies or smoking.
Okay. Remind us what is nephrotic syndrome. Let's jump back to renal disease and also diabetic nephropathy.
All right, let's switch gears to renal disease, starting with nephrotic syndrome and diabetic nephropathy.
Yeah, 2-3 sentences. Don't go crazy.
Nephrotic syndrome is a kidney disorder causing heavy protein loss in urine, leading to swelling, low blood protein, and high cholesterol. Diabetic nephropathy is kidney damage from long-term diabetes, marked by protein leakage and declining kidney function. Both can progress to kidney failure if untreated.
Okay. And how do we distinguish between the two?
Distinguishing nephrotic syndrome from diabetic nephropathy comes down to cause, history, and clinical clues. Nephrotic syndrome is a group of symptoms: massive proteinuria, swelling, low albumin, often triggered by primary kidney diseases like minimal change disease, or secondary causes like lupus, but not always tied to diabetes. Diabetic nephropathy, specifically linked to long-standing diabetes, shows gradual proteinuria, high blood pressure, and reduced kidney function, often with diabetic retinal changes or a history of poor glucose control. Kidney biopsy can confirm. Nephrotic syndrome might show specific glomerular patterns, while diabetic nephropathy typically shows characteristic nodular glomerulosclerosis. Checking diabetes history, blood sugar levels, and other systemic signs helps nail the diagnosis.
Can I ask, when it comes to imaging in renal disease, why is nuclear medicine good for scars and obstruction, whereas MRI is good for arteries?
Nuclear medicine and MRI each have unique strengths in imaging renal disease. Nuclear medicine, like a DMSA scan, is great for detecting kidney scars because it shows functional tissue damage and scarring from infections or reflux with high sensitivity. It's also useful for spotting obstructions, as tests like MAG3 scans track urine flow and highlight blockages in real time. MRI, on the other hand, excels at visualizing renal arteries and blood vessels, especially with techniques like MR angiography, which can pinpoint stenosis or vascular issues without radiation. Each modality targets different aspects: nuclear for function and flow, MRI for detailed anatomy. Want me to dive deeper into one of these imaging methods?
Well, so I want to compare nephrotic, nephritic, CKD, AKI, and kidney stones.
All right, Let's compare nephrotic syndrome, nephritic syndrome, chronic kidney disease, CKD, acute kidney injury, AKI, and kidney stones in a concise way. Nephrotic syndrome is marked by heavy proteinuria, swelling, low albumin, and high cholesterol, often from glomerular damage like minimal change disease. Nephritic syndrome involves blood in urine, high blood pressure, and mild proteinuria, typically from inflammation like glomerulonephritis. CKD is a gradual, irreversible loss of kidney function over months or years, often from diabetes or hypertension, leading to waste buildup. AKI is a sudden, potentially reversible drop in kidney function caused by things like dehydration, infection, or toxins. Kidney stones are hard mineral deposits.
Wait, I'm confused. I don't know how to differentiate. So let's say we have a stone. We will see the stone in the imaging.
You're right. Kidney stones are easier to spot because they often show up on imaging, unlike the others, which rely more on labs and symptoms. With stones, a CT scan or ultrasound typically reveals the stone's location and size in the urinary tract. Plus, you'll see symptoms like severe flank pain or blood in the urine. Nephrotic syndrome shows massive protein in urine tests, swelling, and no stones on imaging. Nephritic syndrome has blood and some protein in urine with high blood pressure, but imaging won't show stones. CKD shows gradual kidney function decline in blood tests, like high creatinine, and imaging might show shrunken kidneys, not stones. AKI has a sudden creatinine spike, often with low urine output, and imaging could be normal or show swelling, but no stones. So, stones are distinct with imaging evidence. The others lean on lab patterns and clinical signs. Want me to clarify a specific test or symptom to help differentiate them?
I want to ask about how to differentiate between nephrotic and nephritic.
Differentiating nephrotic syndrome from nephritic syndrome hinges on clinical features and lab findings. Nephrotic syndrome is characterized by heavy proteinuria over 3.5 grams a day, low blood albumin, swelling, edema, and high cholesterol, often caused by diseases like minimal change disease or diabetic nephropathy. Nephritic syndrome, in contrast, features hematuria, blood in urine, mild proteinuria, less than 3.5 grams a day, high blood pressure, and sometimes reduced kidney function, typically from inflammatory conditions like post-streptococcal glomerulonephritis. On urinalysis, nephrotic urine is frothy with protein but little blood, while nephritic urine shows red blood cells or casts. Nephrotic patients often have puffiness and weight gain from fluid retention. Nephritic patients might have cola-colored urine.
So why nephrotic has these characteristics and nephritic the other ones?
The differences in characteristics between nephrotic and nephritic syndromes come down to the underlying kidney damage. Nephrotic syndrome results from a leaky glomerular barrier, often due to podocyte injury in conditions like minimal change disease. This lets massive amounts of protein slip into the urine, causing proteinuria, which lowers blood albumin, triggers swelling, edema, and ramps up liver cholesterol production. There's little inflammation, so no blood in the urine. Nephritic syndrome, however, stems from glomerular inflammation, like in glomerulonephritis, where immune complexes or antibodies damage the glomerulus. This causes bleeding into the urine, hematuria, mild protein leakage, and inflammation that drives high blood pressure and sometimes reduced kidney function. The inflammatory nature of nephritic syndrome versus the leaky, non-inflammatory nature of nephrotic syndrome shapes their distinct features. Want me to explain more about the glomerular pathology or specific causes?
I just don't understand why. Well, in the name, there is only one letter. O becomes I, and we have so many different. How does the name relate to the traits?
The names nephrotic and nephritic syndrome do seem close, with just that O versus I. but they reflect distinct kidney issues, and the naming ties loosely to their traits. Both come from nephros, Greek for kidney, and describe glomerular disorders. Nephrotic with the O hints at the non-inflammatory, leaky nature of the glomerulus, leading to massive protein loss, swelling, and lipid changes. Think overflow of protein. Nephritic with the I suggests inflammation, as in nephritis, pointing to the inflamed glomerulus causing blood and urine, high blood pressure, and less protein leakage. The single letter difference isn't directly about specific traits, but reflects historical naming to separate non-inflammatory, nephrotic,
So-
from
So nephritic is inflammatory.
Yeah, exactly. Nephritic syndrome is driven by inflammation in the glomeruli, the kidney's filtering units. This inflammation, often from conditions like post-streptococcal glomerulonephritis or lupus, damages the glomerular walls, letting red blood cells leak into the urine, causing hematuria and triggering high blood pressure and sometimes reduced kidney function. That's why it's distinct from nephrotic syndrome, which is more about a leaky glomerulus without much inflammation. Want me to elaborate on what causes that
No, it's
inflammation?
good. It's good. We will see it again anyway. Guys, thank you so much for watching, and I'll see you next time. Peace.